Good afternoon, everyone. Hello and welcome to Sleep Village. I'm Sabrine, your host for today. Sleep Village is your go to community for all things related to better sleep and well being. So today we have Dr. Raj Kakar, founder of Sleep Village and founder of Dallas Sleep, to discuss Airway imaging for sleep health with us. And we will explore how imaging can provide a clear picture of your airway health, helping us understand and address sleep disorders like snoring and sleep apnea. Welcome, Dr. Kakar.
Thank you, Sabrine. Thank you very much. And it's a pleasure to be here today with everybody, and thank you for joining us. It's really exciting for us to have our first live webinar for Sleep Village. So it's an auspicious day for Sleep Village, and I'm grateful for the early and continued support from our community and the sleep community. So this platform is all about bringing people together to improve sleep health, and it's wonderful to see it come to life.
I agree. It's actually wonderful that we have the opportunity to share some of the latest knowledge in sleep health with our community members. Also, we will have some incredible doctors and specialists who will be joining us in the future sessions. So there is a lot to look forward to. And for our viewers, as we go through the presentation, please feel free to post questions to our chat box. After we conclude the presentation, we will have or make some time for Q&A to answer as many questions as we can in the time available. So without further ado, let's begin. Dr. Kakar, you are welcome to get started.
All right, thank you, Sabrine. So let's get started with our discussion for today. And so today we're going to talk about upper airway imaging for sleep health. And so this is kind of a relatively newer field in that historically and conventionally upper airway imaging hasn't been used for and as a kind of routine part of the evaluation for sleep health and in the field of sleep health and sleep medicine. And so I think we're moving to change that. And so I actually have to give credit to the dental community. A lot of the dentists in the dental community regularly take imaging of the airway, whether it's for evaluation of the bite or for orthodontic treatment, and also those dentists that specialize in sleep health also tend to take a good look at the airway for evaluation for sleep health as well. And so that's something that I think the dental community has really been leading this charge and really giving more insight into the evaluation process for sleep disorders. And so that's something I think that the medical community has been lagging behind, but hopefully they can kind of learn from what we have seen so far and taking advantage of upper airway imaging, whether it's a CAT scan or a radiographic imaging for use in the office, can be done very quickly and easily with the upper airway imaging and CAT scanning and digital imaging, really. So it really reduces radiation exposure and those kinds of concerns. And so we see this being done regularly every day in dental clinics around the country. And I think that that's something that gives a lot of value, adds a lot of value to the evaluation process. And so that's something that we have been doing in our clinic here for now about 5 years. And a little over 5 years. And so we have seen it really adds a lot to the patient experience, as well as it helps us to guide us in providing insights as we go through the evaluation and even in managing treatment. So we will talk a little bit more about that as well. So that's kind of where I wanted to start and kind of sharing some of those insights. And so we're going to go through some examples so you can kind of see what I'm seeing, and then we can the things that we typically see here in the office and how that's helpful for us. So I'm going to share my screen here with you for the slides. And so I'm going to share that here in just a moment. Okay, very good. So here we have a first image, and so kind of make that a little larger for you. Okay, so this is what upper airway imaging looks like. We use a digital imaging device here in the office, so it's very minimal radiation and also very easy to use, and you get quick results with imaging. So it's an iCat device is the one we use, and so it works very well. And so, like I said, we've been using it for 5 years plus, and we primarily use it for new patient visits, but it gives us a lot of insight into the airway size and structure and the anatomy there, which of course is very important when you're screening or treating or managing sleep disorders related to upper airway breathing and upper airway breathing respiratory syndromes. So looking at this case first, this example first, I should say, this is a picture of the side of view of the head and neck area, and you can see to the right of your screen is the chin there on the bottom, then the lips towards the right middle, and then here at the top is the nose. Then if you go further here towards the left, there's the lower jaw, the upper jaw, and the front teeth there. Behind that, on the left in the middle of the screen, is the tongue, which is usually a large part of the airway, of the oral cavity, I should say. And behind the tongue here, then you see the back of the throat. Coming from this upper jaw here is the soft palate and uvula, the tissue that hangs from the back of the throat, the roof of the mouth, and that soft palate and uvula typically kind of sits behind the tongue, so there is some overlap there. And it's where that overlap occurs that oftentimes we see the most narrowing in the upper airway. In some cases, there may also be narrowing further down, directly behind the base of the tongue. That's another area which can also contribute to breathing disturbance. But so we're primarily looking at these two areas, the area where the soft palate and uvula sits, and that again is behind the tongue, so where they overlap, that area tends to see some narrowing in cases where people are predisposed to having sleep-related breathing disorders. And then further down, sometimes behind the base of the tongue, there can also be some narrowing there. So typically what we do is we will do the imaging to see kind of where the most narrow areas are and where they fall in. So in this example, you can see there is most narrowing is right here behind the soft palate, as minimal as 4.95 or 5 millimeters, you could say, of space there. So that is considered narrow based on our experience of imaging hundreds of patients over the last several years. We found in our experience that when this airway diameter, and whether it's here and behind the soft palate or even further down behind the tongue, when that diameter is less than 10 millimeters in men, that increases the risk for presence of snoring and sleep apnea. So the more narrow, the higher the risk for snoring and sleep apnea. And so it gives us a pretty clear idea that this is kind of where the problem is coming from. So if somebody who has a 4 or maybe 5 millimeter narrowing there of space in the upper airway, that person is definitely at high risk for snoring and sleep apnea, and most likely this is where the problem is occurring. And so so it really gives us a clear insight into where actually the problem is coming from, because that's something we get asked all the time by patients and people who come to see us is, where is the problem? Where is this coming from? Where is my snoring coming from? And a lot of times people have a misconception that snoring is coming from their nose. And that, although that may be the case in some situations, most often, usually snoring, majority of cases, is coming from the back of the throat, whether it's the soft palate area or the base of the tongue or a combination of the two. This is really where snoring occurs in the large majority of people. So, so this really helps us to get better insight into where the problem is. And as I mentioned in men, that number that magic number appears to be 10 millimeters. So if it's below 10 millimeters, there's an increased risk for snoring and sleep apnea. If it's above, it doesn't mean they don't have it. It just means maybe less likely to be an issue. Similarly, in women, we found in our experience over the last several years that the magic numbers in women seems to be about 8 millimeters. So in women, if they have less than 8 millimeters of space available there for the diameter, minimum diameter, they are at increased risk for snoring and or sleep apnea. And similarly, if it's above 8 millimeters in women, it doesn't rule it out, but it may be less likely. So this is another very helpful tool that we've been using in our clinical practice, and I find that it brings a lot of value not only to us to help us identify what that looks like and where the problem may be occurring, but also it helps the patient to see this. This is something we share with our patients so they can really get a better sense of what their airway size and structure looks like, and how that can be how that can really play into their diagnosis and their treatment. So it's actually really very helpful in that regard to really give more information and more insight. So we'll go into the next one here, the next slide. This one is another case where you can see the anatomy is different. So of course, different people, different anatomy. In this case, you can see there's the chin, lips, nose, lower jaw, upper jaw, front teeth, tongue, and then the soft palate here. And so here we're seeing narrowing in a couple of areas. Behind the soft palate and uvula, where the overlap is with the tongue, it's as minimal as maybe 5.5 or so millimeters of space there. And further down behind the tongue, it's also about 8 millimeters, so 8.5 millimeters of space. So that also is narrow as well, maybe not as much. But the other thing we have to keep in mind is this imaging is being done when the person's awake and they're sitting down in a sitting position when they're getting scanned. And so when you're sitting down and being scanned and you're awake, there's going to be more airway space compared to when somebody's lying down in bed and they're preparing to go to sleep. In those cases, we know just from gravity and being more relaxed, everything's going to be more narrow in that situation. And when they're actually getting into sleep, this can become much more narrow as compared to what it appears to be during the daytime. Similarly, when somebody's going into a deeper sleep, when they're sleeping, we know the lower jaw tends to relax, and that allows the tongue to drop back further during sleep. So when somebody's actually sleeping, their lower jaw tends to relax, and the tongue, which is attached to the lower jaw, will also fall back, the base will fall back further, causing more narrowing down here. So although it may not appear as narrow here behind the tongue to begin with, it definitely can become more narrow during sleep, especially during deep sleep at night. So that's something to keep in mind as well. So although we're looking at it when the person's awake because that's the easiest way to image it, we have the understanding that this is a best case scenario. It's always going to be more narrow when somebody's sleeping. How much, it's difficult to say, but at least we have a baseline here to kind of indicate to us where they fall in. And again, those magic numbers I gave you for a baseline of 10 millimeters or less in men and 8 millimeters or less in women is based on when they're awake in a sitting and upright position. So in this case, again, we see it about 5 to 6 millimeters at a minimum. So again, this person does have increased risk for snoring and sleep apnea, especially based on this area. I'll go on to another image here. This is another one which again shows narrowing here primarily behind the soft palate uvula and the tongue overlapping area in the upper airway here. It's right around 7 to 7.5 millimeters of space. So again, there is some narrowing there, which would put that at increased risk for snoring and sleep apnea. Here's another interesting one which shows even more narrowing than some of the previous cases. So in this case, you can see, the tongue is there, soft palate uvula is up here. Of course, it can be difficult to see the soft palate uvula in some cases because it sits directly behind the tongue. They kind of overlap, and so they kind of blend together. But the soft palate uvula is here in this area, and just sitting basically on the back of the tongue. But it's where they overlap that we do see some narrowing here, as little as 5 millimeters higher up, and further down where maybe the uvula appears to be and the tongue overlap is as narrow as 3 millimeters. 3 millimeters of space. Not a lot of space. We're talking about a couple of pencil tips put together is what you get. And this is when they're awake. So when they're asleep at night, this is going to be even more narrow, very likely even possibly collapsing completely at times, which can ultimately contribute and cause obstructive sleep apnea. So this is kind of what we typically see in many cases of people who come to see us. The airway's narrow, and so there's really not a lot of space to begin with. And even behind the tongue, further down here, there's not much space, less than 5 millimeters of space. So it's very likely this individual will have collapse both behind the soft palate uvula and even behind the tongue, where it can impact, likely to impact their breathing when they're asleep at night. Here's another one, and this is again to show you that not everybody has a totally narrow airway. This one actually looks a little bit better in that there is not as much narrowing, but still it is narrow. It falls within the narrow range for a male. 8.4 millimeters of space is less than 10. So again, there is some narrowing there, and so that does indicate, again, behind the soft palate uvula area, 8 millimeters or so is likely to be the area where they may have the highest predisposition to having snoring and or development of sleep apnea. And just to point out right here, this is the behind the tongue, I should say. Here we have the epiglottis. The epiglottis is what kind of closes off the windpipe, so it allows the epiglottis actually closes off for the esophagus, so that way somebody's able to, during swallowing, they're able to still continue to breathe, but the epiglottis protects the esophagus, so no liquid goes down or aspiration occurs. So that's just kind of what this is showing here. Another case here which shows somebody with a narrow airway further down, again behind the tongue, soft palate, uvula, tongue area. Back here, especially looks to be primarily the base of the tongue. It's around 4 millimeters or even a little less than 4 millimeters of space. So again, this individual is more likely to have problems with their airway in this area behind that tongue base, which again, uvula tongue base area, which again can contribute to snoring and even obstructive sleep apnea. And then here's another one, another example that just shows again some narrowing in the same region, around 4 millimeters of space. So you're starting to see, some common themes here. This is another example where there seems to be more uniform narrowing throughout the upper airway, both behind the soft palate uvula and even further down behind the tongue, where it's pretty uniform, anywhere between 5 and 8 millimeters of space. Not a lot of space there, and so that's pretty consistently narrow all the way through, up and down in the upper airway in the back of the throat. So again, this person may have difficulty with snoring and breathing due to collapse in more than just one area. It may be kind of more uniform collapse there. Here's another example of a very narrow upper airway, again primarily behind the soft palate uvula area. Here it's going as narrow as 3 millimeters of space, which again is quite narrow, leaving not a lot of airway, especially when even they're awake, but even more so when they're sleeping at night. This is going to be even more relaxed and collapsed, so really contributing to difficulty with snoring and very likely obstructive sleep apnea. Here's another example here which shows the airways narrow behind the soft palate, but even again further down behind the soft palate uvula areas where it's even worse, as narrow as again 3 millimeters, which seems to be a common number here, but that's not a lot of space. So we found again less than 8 millimeters in women, less than 10 millimeters in men, increases somebody's risk for having snoring and obstructive sleep apnea, and that seems to be usually where the primary problem occurs. And further down you can see there is some narrowing here as well behind the base of the tongue in that area. Next slide here again showing a little bit different pattern, but again you do see most of the narrowing seems to be behind the soft palate uvula and base of tongue overlapping area, in this case around 6 millimeters of narrowing. Moving on to the next slide, here's another case where it shows quite a bit of narrowing, and it's a fairly uniform narrowing throughout, but there is most of the narrowing even occurring again at that same, typically the area which seems to be a problem in most cases, just based on our review today, is that soft palate uvula area where it overlaps with the tongue, is where we see predominantly most of the narrowing occurring in many people who are affected by snoring and sleep apnea. And here in this case, it's again around 3 to 4 millimeters of narrowing there when this person had their imaging performed. The next case here is another narrow airway where we see the narrowing is quite even further pronounced. And so we see a narrowing as little as 2.5 or so millimeters. So not much space there in this area, again, in the upper airway behind the soft palate uvula, and even further down behind the tongue as well. Another image here is showing kind of a similar pattern behind the soft palate uvula, 3 millimeters or so of space, not much space here. So this person is very likely to have significant snoring and obstructive sleep apnea. And here's another example where we have some more evidence of narrowing here in the upper airway, around 4 to 5 millimeters of space when this person was imaged sitting up. Another example of a narrow airway here. This is as narrow as 2.5 millimeters of space. Not much space at all. If you think about it, we're talking 1 or 2 pencil tips of space, of airway space. So we have it blown up here so it looks really big, but in reality, it's not much airway space when this person is awake. So they must struggle to breathe at times when they're awake, especially during exertion, but even more so when they're trying to sleep at night. This is really where they can have difficulty breathing, which can contribute to snoring and obstructive sleep apnea. Here's another one which doesn't show as much narrowing, but there is some narrowing down below 8 millimeters, down in the 7 millimeter range. Especially this one is more so behind the tongue. So it's not as bad higher up here behind the soft palate uvula, but really once you get down to the level of the tongue, it's actually a little bit more narrow, around 7 millimeters or so. So this person really has more of an impact perhaps by the tongue, and when the jaw relaxes during sleep, the tongue base may be contributing more to the snoring or obstructive sleep apnea problem. And here's another case. This one just goes to show you that not everybody has a narrow airway. This is a good example of something that may be closer to a more normal airway size and structure. Here you can see up here there's about 11 to 12 millimeters of space there. Further down, 15 millimeters of space, which looks great. Here in the middle, at the primary area, which usually is a problem area for people with snoring and sleep apnea, it's right around 10 millimeters. So it's just below 10 millimeters. So again, this person may have some snoring. Whether they have obstructive sleep apnea remains to be seen during their evaluation, further evaluation, dependent on that. But at least based on this, the airway size looks reasonable, although again, there may be some increased risk for obstructive sleep apnea based on this imaging. But again, it shows a much more airway space and size relative to some of the other images that we've been looking at. Here's another image of somebody who has some narrowing behind the soft palate uvula area, around 6 millimeters of space there, and about 8 to 9 millimeters of space further down behind the tongue. So again, some evidence of upper airway narrowing and that. Now this one I really can show you. It's just really significant, you know, down around 2.5 millimeters of space. Again, a very narrow airway, so very likely to have snoring and obstructive sleep apnea just based on looking at this narrowing there. And it's pretty pronounced. Just looking at it, you can see there's not a lot of space there. And again, this person is awake and sitting up. So when they're asleep at night, it's very, very likely to be very collapsed and obstructed to allow them to breathe comfortably when they're asleep at night. Here's an image of a similar finding where they have some narrowing here behind the soft palate uvula, around 3 to 4 millimeters of space. And so that shows that they're having some narrowing there. There is also a little bit narrowing down here as well. But what I wanted to show you really is kind of where the problem tends to occur. It does seem to be that soft palate uvula is a very common contributing area to obstructive breathing during the night. And then in some cases, the base of the tongue also can contribute. So those are really the two primary areas that contribute to snoring and obstructive sleep apnea in our experience. Now, one thing that also we keep in mind as we further our discussion here, not only in our evaluation when we're looking at these images, we want to see kind of what that looks like, first of all, to give us an indication of where the problem is, as well as how likely they are to have, some snoring or sleep apnea. But also it guides us, gives us some guidance as to which treatment will work best for them, because it's also giving us a clear indication of most likely where the problem is in their airway that's contributing to obstructive sleep apnea and snoring. And so really we could tailor the treatment to make sure we're really addressing the problem areas. And so in this case, again, you're seeing quite a bit of narrowing here in the upper airway behind the soft palate, and it appears to be about 2 millimeters or so of space there at this imaging. In this case, wow, look at that. It's practically, this is what you call kissing tonsils practically. So this person is having a very narrow airway where essentially there's really hardly any space, less than a millimeter of space. So we're talking less than a pencil tip of space width here in the back of the throat, behind the soft palate and uvula, directly behind the soft palate and uvula, 1 millimeter, and in this case it appears to be less than a millimeter, practically kissing. And so this is very obstructed. So this person may be breathing heavily even during the daytime, but for sure at night they're likely to have difficulty breathing and snoring. They're likely to be snoring, because of this airway anatomy. But again, going back to our discussion of treatment, so the most common treatments for obstructive sleep apnea are CPAP, which again is the continuous positive airway pressure device, which can help to maintain the airway by blowing air, which will help blow air through the nose to keep the nasal passage of the nose as well as this upper airway open. So CPAP blows air to keep the entire airway column right here behind the soft palate uvula and even the base of the tongue to keep that open. So at least it stays open, similar to what they have when they're awake. So at least they're able to get some air by, and that way help prevent and reduce snoring and obstructive sleep apnea. So that's how CPAP works. So the other option, which is used in some cases for managing snoring and obstructive sleep apnea, are oral appliances. Oral appliance treatment or mandibular advancement devices are used to reposition the lower jaw to keep it positioned forward. So essentially pulling or repositioning the lower jaw forward to the right, so that way it increases the space back here by moving the tongue a little bit towards the right, so it doesn't drop back as much when somebody's sleeping. So the mandibular advancement devices can be helpful, especially in mild to moderate cases where they're usually limited to mild to moderate cases where they can at least move the lower jaw to an extent where the tongue is prevented from dropping back as much, which is helpful to reduce the snoring and obstructive sleep apnea. However, we do know that mandibular advancement devices are limited in how much they can be repositioning the lower jaw and the mandible. So that does limit their efficacy because of development of discomfort or jaw positioning problems. The other thing we keep in mind, and just looking at this image here, which will give us some insight to that, is when you reposition the lower jaw, it does help with keeping the tongue further out of the way, which may have some indirect impact on the soft palate too, but it doesn't directly impact the soft palate. And I think that's where CPAP has an advantage over the oral appliances, which clearly it does. It's because CPAP is blowing air to keep the entire airway column here in the upper airway open, whereas oral appliances help to reposition the lower jaw and the tongue, but they don't really have a direct impact on the soft palate. They may have an indirect impact by moving the tongue forward a bit, but they don't have that direct of an impact on the soft palate, which may still drop back and relax when somebody's sleeping. And so that can still be a problem in many cases. And so that's where, again, CPAP has an advantage. But again, you can see that seeing the airway size and structure here, that can help to guide the treatment when you're considering that. Again, here's another good example. So this is showing airway anatomy with narrowing here in the lower part of the airway around 3 millimeters and several areas here behind the base of the tongue. So in this case, perhaps there's not as much airway we see in narrowing. We see upper airway behind the soft palate. It seems to be better there. So perhaps this individual may be a good candidate for oral appliance treatment or mandibular advancement, because by moving that mandible forward and the tongue forward, that would have a direct impact on this narrowing we're seeing down here. And so this person may be a good candidate for oral appliance. So now you can see how we're thinking through the management and treatment of cases like this, not only in the diagnosis to help us kind of confirm the diagnosis and see where the problem actually is occurring when somebody's snoring, but it also can guide us for treatment and to kind of really consider what treatment options may be most efficacious in each individual case. And so here's another example you can see of narrowing here in the upper airway behind the soft palate uvula, again down around 3 millimeters of space. So again, this person would likely benefit from treatment once the diagnosis is confirmed with a sleep study. Then we could consider treatment with CPAP or perhaps an oral appliance, depending on the situation and the analysis of the evaluation. But again, in this case, there's narrowing primarily in the soft palate uvula area. Another example, similarly, of some narrowing in the soft palate uvula area around 3 to 4 millimeters of space. So we're kind of seeing that same type of pattern here. So again, in somebody like this situation, although an oral appliance may be helpful to reposition the tongue forward, it may not be completely effective because they still may be having some contribution from the soft palate uvula here, which very well could still contribute to collapse and snoring and obstructive sleep apnea. And here's another example where you can see quite a bit of narrowing here down to 2 millimeters of space, quite a narrow airway here. So again, that also appears to be occurring at the confluence of the uvula, soft palate uvula, and the base of the tongue, where they all come together. One more image here showing some further narrowing in the same soft palate uvula region, not as bad further down behind the base of the tongue. So again, this individual may not be an ideal candidate for an oral appliance because they're not having as much narrowing here behind the base of the tongue. So to reposition that forward may help indirectly to some extent with the soft palate uvula area, but it may not have enough impact to well control or get good control over the obstructive sleep apnea and snoring. Again, it depends on their sleep study results and what the entire case looks like, but it does give at least another piece of information to consider as clinicians and sleep doctors are evaluating and making a treatment plan tailored for each individual patient. Here's another airway where you can see, wow, that's quite a bit of narrowing here, 1 millimeter behind the soft palate uvula area, so quite a bit of narrowing. And even further down behind the base of the tongue, it's down to about 3.5 millimeters of space. So quite a bit of narrowing all the way up and down through. So this person is very likely to be, suffering from snoring, probably loud snoring and obstructive sleep apnea. One more example of quite a narrow airway. You can see here 1.5 millimeters space, quite narrow. So it really shows you kind of where the problem is, and behind that soft palate uvula area. And so that's really where the problem is. So again, it kind of helps us to evaluate that in making our decision making for management and treatment. And one more interesting airway to see, this one you can see it's quite consistently narrow all the way up and down from the soft palate uvula all the way back to the base of the tongue. In this case, it's as narrow as 1.5 millimeter down here, back down in the base of the tongue, and even as narrow as 2 millimeters or so behind the soft palate uvula area. So quite a bit of consistency there, so quite narrow. And so this is also highly likely case of snoring and obstructive sleep apnea, which is probably on the severe side, just based on looking at the anatomy there. And another example of a quite narrow airway up and down, pretty consistently all the way through, right around 2 to 3 millimeters. So pretty consistently 2 to 3 millimeters of space, quite narrow, up and down. Another example of the airway imaging here showing most of the narrowing occurring behind that soft palate uvula area behind the tongue, in this case around 2 millimeters or so. And one more example of a narrow airway primarily behind the soft palate uvula, between 3 and 4 millimeters, right around 4 millimeters on the narrow side, which again primarily appears to be behind the soft palate uvula, not so much the tongue. So again, in this case, somebody with a mandibular advancement device to reposition the tongue forward, it may help a little bit indirectly, but it may not give them as much benefit perhaps as CPAP, which would directly keep this soft palate and uvula airway open and out of the way so it doesn't collapse further from this position. So that again is something to consider when evaluating and managing this case. And so I think that's the last one there. So I'm going to stop sharing the slides and come back to the primary discussion. And so, so kind of going back to what we were discussing, I want to just kind of bring it again to the point that upper airway imaging is very helpful. It's used in many dental offices and clinics around the country here in the U.S. And I think a lot of dentists get first insight into what the airway looks like, even more so than many of the sleep doctors and physicians who are also managing and treating or evaluating for sleep apnea and snoring. So it's a really great tool, and I think it's something we can use more and more because it's readily done in the office and can be done pretty quickly. And you can share the results in the imaging with each patient right then and there and discuss that and really show them where the problem is or where it's coming from, which is contributing to their snoring. And so it's really helpful in that way. And also it can be helpful to guide treatment as far as evaluation and treatment, because it can help to determine what treatment options may be most beneficial for them, whether it's CPAP or an oral appliance based on the anatomy that's there. So without further delay, I will turn it over to Sabrine so she can help us to maybe address any of the Q&A.
All right. Wonderful. Thank you very much, Dr. Kakar, for that insightful presentation. And it's quite fascinating to see how airway imaging can provide such insight into diagnosis and management of sleep disorders. And yeah, let's get started. We have enough time for some Q&A. And yeah, let's see.
All right. So, Sabrine, do you have any questions for us here?
Yeah, we have a few questions coming up.
Yeah, it looks like Mari Chris has a question.
All right. So from Mari Chris, she has a question. Is there a good side to sleep to lessen the snoring?
Yeah, that's a good question. And so, yeah, typically snoring is usually worse when somebody's sleeping on their back just because of the direct impact of gravity. And so the base of the tongue falls directly back into the back of the throat. So usually snoring is worse when you're sleeping on your back. So ideally we recommend people sleep on their sides to lessen snoring. And most people naturally will start moving to their sides to snore, to help manage the snoring and so they can breathe more comfortably. So we do recommend ideally sleeping on your side if somebody's having snoring problems. We don't recommend sleeping on your stomach for adults because that can actually put more strain on the lower back and can contribute to back problems or back pain. So we don't typically recommend sleeping on stomach for adults. All right, let's see, is there another question? I guess Marissa has one.
Yeah. So her question, can sleep apnea be caused by chronic sinus congestion or nasal obstruction?
That's a good question, and I don't know that we have a clear answer on that, but it seems that it's possible that chronic sinus congestion or nasal obstruction could contribute to sleep apnea, but I don't think there's a direct correlation there between chronic sinus congestion, nasal obstruction, of a direct correlation to resulting in sleep apnea. I think there are two different conditions, but having some chronic sinus congestion, nasal obstruction can increase the risk to obstruction of the airway, which can contribute to possible snoring or sleep apnea, but it's not a direct correlation. All right, well, let's see, did you have some other questions, Sabrine? Looks like there's a couple of other questions there that were turned in before the talk, looks like, when we were beginning.
All right. Yeah, so we have a few. Okay, next question that we have, what are the common symptoms of sleep apnea?
Yeah, that's a good question. So, common symptoms of sleep apnea are snoring. That's the most common one. But there are other symptoms because snoring in women is not always loud or frequent. And so, in women, actually, it can be more difficult to make the diagnosis of obstructive sleep apnea because usually snoring is not present, or if it is, it may be more subtle. So, snoring is just more common in men, but that is one of the symptoms. Other symptoms in both men and women can be frequent awakenings at night, waking up less frequently. I'm sorry, waking up more frequently during the night, and having difficulty staying asleep. Those are also common symptoms, as well as waking up just feeling tired or unrefreshed in the mornings, and then feeling more tired or even drowsy or sleepy during the day. These are some of the common symptoms we see. And in some people, they wake up more frequently during the night and actually have to urinate to go to the bathroom more often. So they may be getting up 2, 3, 4 times a night to urinate. That also sometimes can be related directly to sleep apnea. So those are some of the common symptoms to keep an eye out for.
Looks like we have a question for CJ and Margaret.
Yeah, I think there was one from Kent. I think we had one earlier from Kent. If you can look at that one. I
Okay,
think
sure.
it was about uh, diagnosis.
Yeah, I have one here. How is sleep apnea diagnosed?
Yeah, so that's a good question, which we didn't talk much about during the presentation. But sleep apnea is often diagnosed primarily through a sleep study. And so sleep studies historically have been done in a sleep lab where you go and spend the night and they evaluate you during your sleep. But now, over the last several years, the technology has improved. So now we have home sleep testing. So home sleep testing is now the most common way to make a diagnosis of obstructive sleep apnea. And so we can do home sleep testing, and that's where a device is given to the individual to take home and use it for 1 or 2 or 3 nights to get some data and to see and to measure what's going on with your breathing. Also to measure, if there's snoring, as well as any obstructive sleep apnea or other types of sleep apnea in some cases. The home sleep study also measures your oxygen level, so it can actually help to determine if there is effects on the oxygen level during the night because of breathing problems. So it's also helpful in that regard to really get an idea of what degree that's occurring. So with a home sleep study, that's really the most common way to make the diagnosis of obstructive sleep apnea.
And then we have a follow-up question. Where can I go for help?
Yeah, that's also a great question. So going for help, really, you can talk to your primary care doctor to see if they can guide you to get a home sleep study done. Also, you can seek out a sleep doctor or sleep specialist directly. In many cases, usually referrals aren't required unless your specific insurance requires a referral. But you can directly contact a sleep doctor or sleep specialist in your area, and you can find them online. And then lastly, there are other companies that are offering some services online as well for those that are looking for help more conveniently or maybe don't have insurance. There's companies like snoringandfatigue.com that provide services online and through virtual visits. So snoringandfatigue.com is another resource for getting help. But I'll read the last question from Margaret. It says, can home sleep studies adequately evaluate upper airway obstructions? That's a good question. So yeah, home sleep studies do help us to at least confirm whether somebody's having snoring or some form of sleep apnea, most commonly, obstructive sleep apnea. So most home sleep studies do give us good information about that. So nowadays we're able to get some good data. Do they adequately evaluate upper airway obstructions? I guess to make the diagnosis of obstructive sleep apnea, they can be helpful in that regard. Unless somebody has a really mild case, home sleep study may not be as sensitive to pick up some of the milder cases. And so just because you have a normal home sleep study doesn't mean you don't have it, especially if the suspicion is higher, if somebody's having symptoms, then it may require a further evaluation with an in-lab sleep study. So there are some cases where a home sleep study may not be enough to confirm the diagnosis, especially if maybe somebody's having a more subtle or milder case. So in those cases, an in-lab sleep study can really help to answer that question, depending on symptoms and suspicion. So yeah, so I hope that answers the question, and thank you all very much. Now it looks like we have Sabrine back, and so thank you, Sabrine, for your help today, and appreciate it.
All right, no problem, Doc. And yeah, thank you so much, everyone, for joining us for today's webinar. We hope that you found this insightful, and we look forward to providing with more valuable content at Sleep Village. And a big thank you to Dr. Kakar for sharing his expertise and valuable insights on airway imaging and sleep health. I also encourage everyone to continue to engage with our community. Your participation is what will help us continue growing and offering valuable resources. Let's work together to make Sleep Village a place where everyone can find the help and support they need for better sleep. And also, we are excited to let you know that our next webinar will be on the topic of sleep and obesity with Dr. Atul Malhotra. And this session is scheduled on October 17 at 12 noon Central Time. So be sure to mark your calendar. And we hope to see you there. Thank you once again for joining us today. And until next time, sleep well from all of us at Sleep Village. Bye, everyone.
Bye.